Hello, and thank you for joining today's webinar, The Science of Prevention, presented by the Office of National Drug Control Policy. We will begin shortly with Janie Delano as our ONDCP webinar moderator. We will first hear opening remarks from Michael Botticelli, Director of National Drug Control Policy. Next will be a keynote address by Dr. Wilson Compton, Deputy Director of the National Institute on Drug Abuse. Thereafter, we will open up today's conference call to answer any questions you may have. Dr. Compton will facilitate the question and answer session. Finally, Michael Gottlieb, the Director of the National HIDTA program, will provide closing remarks. Now I will turn it over to Janie Delano, who will introduce the first speaker.
Good afternoon and welcome. I am pleased to introduce our first speaker, Michael Botticelli, the Director of the National Drug Control Policy. Director Botticelli was sworn in as director on February 11, 2015, and has more than 2 decades of experiences supporting Americans who have been affected by substance use disorders. Welcome, Director Botticelli.
Great. Thank you, Jamie. It's really a pleasure to be here, and thank you for everybody on the line who's joining us for today's webinar, The Science of Prevention. I'm really excited to have the opportunity to kick off this webinar and to welcome Dr. Will Compton from the National Institute of Drug Abuse. And this is, I think, a really important program to really look at and provide an introduction to evidence-based prevention strategies and provide information for our HIDTA programs. So next slide, please. A few things that I think probably everyone has seen before, but just want to kind of keep in front of mind as we do this presentation. So, obviously our national drug control strategy sets up a series of actions for all of us at the federal level and provide a blueprint at the state and local level in how we're its consequences in the United States. And kind of no surprise that the first principle of our reform policy is to prevent drug use before it ever begins. And I think the important point and the important part of the conversation today, which we'll really explore, is that we know so much more today in terms of when we talk about the science of addiction, that we know so much more about evidence-based prevention programming that we wanted to make sure that we share you as we look at the work that we're doing. And I know that many HIDTAs are already focused on prevention efforts, and some of you already work with our drug-free communities. So I think this is just a continuing effort to cement efforts at the local level across the spectrum of prevention, treatment, recovery, and law enforcement services. But I also think it's important that we all know we have limited resources, so we want to ensure that our limited resources are used in ways that we know to be effective. Next slide, please. So this is a little bit of a busy slide, but if you look at the bottom in terms of the red and green, the takeaways here is that we know that there are risk factors that contribute to the probability that people will use substances. And in essence, the opposite of those are protective factors. So a goal of prevention reduced to its most simplistic terms, and I hope Dr. Compton will forgive me, is to really reduce the risk factors that exist at the individual level, at the family level, with people's peers, at the school and community level, and elevate protective factors that we know reduce the probability that people will use substances. So again, we know that our programs need to be evidence-based, they need to be targeted, and they need to be focused and culturally competent. Next slide, please. I want to talk for a minute about the other grant program that ONDCP puts out to the communities. And yes, ONDCP does have another grant program other than HIDTA. It's called the Drug-Free Community Support Program. I know many of you are familiar with these. This is a federal grant program funded through our office and with the collaboration of SAMHSA that provides funding directly to community-based coalitions to prevent youth substance use. I think we all know that local problems require local solutions, and these grants provide dollars to local communities to support examination and assessment of what the drug use issues look like in a given community and implement community-based strategies to deal with this. This program has been in existence since 1997 and has been one of our efforts, significant efforts around drug prevention. We will shortly be releasing an evaluation of DFC programs that I hope you take advantage of. And again, I know that many of our HIDTA programs have done an incredible job at reaching all sectors, not just the law enforcement community, but have gone above and beyond in terms of reaching out to all sectors of the communities. But we see a unique opportunity to really expand collaborative efforts between HIDTA programs and our DFC awardees. Next slide, please. So this is a really interesting map, and on our website you can find a list and a map of all the 2014 DFC awardees in each HIDTA district. And staff put together an example of that, of 2015 DFC awardees in the DC-Baltimore HIDTA district. We'll include a link to the resource at the end of the presentation so you can find out which DFCs are in your district, and we would really encourage each HIDTA director and their staff and their teams to reach out to your local DFCs to discuss opportunities to understand their work and to develop coordinated strategies on substance use prevention in your community, and our staff can provide you with this information. So again, I really want to thank everybody for participating today, and we hope that the information and resources will continue to inspire you to improve the quality of prevention programming offered through your HIDTA program. So thank you, everybody, and I'm going to turn it back to Jamie, who's going to introduce Dr. Compton.
Thank you, Director Botticelli. We would now like to introduce Dr. Wilson Compton, Deputy Director of the National Institute on Drug Abuse, NIDA, at the National Institutes of Health. Dr. Compton is an MD and the Deputy Director at NIDA. He provides scientific leadership in the development, implementation, and management of NIDA's research portfolio and works with the directors to support and conduct research to improve the prevention and treatment of drug use and substance use disorders. Dr. Compton has achieved multiple scientific accomplishments. In 2013, he received the prestigious Health and Human Services Secretary's Award for Meritorious Service. We are pleased to welcome Dr. Compton here today. After hearing his presentation, we will open the lines for questions. Welcome, Dr. Compton.
Well, thank you very much, Jamie, and thank you, Director Botticelli. It's certainly a pleasure to be here today to speak to the representatives from the HIDTA organizations spread out all across the country. It's a bit daunting to be here in a padded room conducting a lecture with what I hope are some very engaged people sitting at your desks or in small conference rooms spread across the country. Typically, I like to allow myself to be interrupted for questions, but given the format, please save your questions for the end, but I love to have an opportunity to have a lively exchange, so feel free to save up your hard questions, and there are already a few submitted that we'll be happy to entertain when I'm all done here. Next slide, please. I'm going to provide for you an overview of what we see as some of the principles that guide the development of prevention interventions. Now, this certainly won't be a comprehensive review of the different approaches that you might consider for your communities or your organizations to undertake when you want to prevent the onset of drug use in your communities. But I hope it'll give you a flavor for how the science has progressed to how we determine whether an intervention is effective as prevention and what underlies our understanding of that. And then we can certainly point you in the direction of how to obtain the resources you might need to make the actual selection for your communities. That's, after all, in the long run, what your most important challenge will be. Now, there's a fundamental lesson when it comes to drug abuse and drug addiction that's been brought about by a revolution in science over the last 20 years. We've finally been able to use scientific techniques, and in this case, imaging techniques, to look inside the brains, inside the skull of people with substance use disorders. That's very similar to what medicine has been able to do for heart patients or for kidney patients or for liver patients for decades. But just by example, what you see on the top slide, on the left, labeled control, is looking down at the brain of a normal person. And what you see highlighted in sort of yellow and slightly red is the amount of blood flow or sugar metabolism in different parts of the brain. So we're looking down, and you notice that there's a lot of activity, a lot of red and yellow in the top part. That's the front part of the brain, just behind the eyeball. So that's the frontal lobes of the brain, and normally they have a lot of activity. They're the seat of our judgment, decision-making, and what makes us human beings. Notice that on the right-hand side, the cocaine abuser has less blood flow in that region. This is not just a general effect, but we think that that speaks to the difficulty with judgment and decision-making and the difficulty in controlling their own behavior that cocaine abusers have, which is part and parcel of being a drug addict, is that difficulty resisting temptation and saying no. And we think that's partly due to abnormalities in the frontal lobes of the brain. Well, just like we can now image brains and detect differences, heart researchers have been able to do this for several decades. And as you see, just like we can do now for drug abuse patients, for a heart patient, you see on the left a lot of blood flow in the heart muscle, and you see on the right somebody that might have had a myocardial infarction has much less blood flow in the walls of their heart. That's really at the core of some of the revolution in science that has allowed us to begin to unravel what previously had been total mysteries about why people behave the way they do. Now we're finally beginning to link it to where the behavior originates, which is, of course, in our brains. Next slide. If we want to prevent drug abuse, we need to think about what the causes of drug abuse are. And so the fundamental model that we use is that drug abuse and addiction is, of course, caused by the drugs themselves. So exposure to the drugs is a key factor, and that's part of the mission of the HIDTA program, is to keep drugs out of our communities. So in many ways, what you all are doing fundamentally is a prevention activity. But when I think about prevention, I'm thinking about how individuals are at risk for addiction and substance use problems, and that's a combination of their innate vulnerability, that might be their genetic makeup. So having parents, grandparents, and siblings is a clue that addiction runs in a family and might have a genetic background. But it's not just the genes. It's also complex environments and multiple aspects of the environments, whether that's the family environment, the school environment, the neighborhood, even the laws and social policies can make a big difference in terms of whether someone will go on to develop a drug use problem. So fundamentally, it's what keeps me engaged and many of the scientists engaged is that it's such a complicated picture. It's not just the brain and the biology, but it's the brain and biology combined with environmental factors. Next slide, please. So that's sort of lesson number one, the importance of the environment, and we'll come back to that because after all, when we talk about prevention, we are manipulating the environment to make people healthier and keep them healthy. Another key principle in the science of prevention is that addiction tends to start when people are young. On the top part of this slide, you see something called a hazard rate. So that means in the population, at what ages do we see the onset of drug abuse or drug dependence? That's what the Psychiatric Society, the American Psychiatric Association, uses to classify addiction, abuse, or dependence. And we see that the onset is typically during the teen years. That's a major clue. It certainly doesn't surprise everyone. We've known that for a long time, that adolescence is a major period of risk for a variety of behaviors, including drug abuse. What's going on during adolescence? What you see on the bottom of this slide are a series of representations of brain development. And so you can see at different ages that the brain is shifting in its connections, in the pathways, and its relative maturity. Adolescence is a period of phenomenal growth and development of the brain. There are two major periods of growth. The first is from just before birth up to around age 5 or 6. And the second huge growth spurt for brain development would be during the adolescent period. Of course, our brain is always being modified and changed throughout our entire life. I hope that every one of us will be able to grow and to develop and learn things our entire lives. But there are certain periods of time when it's particularly significant, and adolescence is one of them. We think this growth spurt in brain development may be key to why adolescents engage in drug-using behavior. And it really doesn't, it's rare for it to start before about age 12, and it's also rare for it to start after about age 25. So that's a clue that there's something about adolescence, and if we can keep adolescents safe and on the right track, we may have really saved their lives in many ways, many times. Next slide, please. When we think about the onset during adolescence, though, I want you to realize that that's just when it expresses itself. The roots of addiction start much earlier. So let's look at at least one example of how early childhood can influence long-term outcomes and long-term behavior. There's a remarkable story that came out of Eastern Europe. The orphanages in Romania were an example of extreme deprivation. There were a large number of babies who were put in orphanages, and they were taken care of in terms of their food and basic sustenance, but they were tremendously neglected in terms of their social interactions and their opportunity to grow and develop because of interactions with parents or with family or with other humans. And what we found, this group found, is that when they looked at the brains of those children who had been severely neglected during early childhood, they were much more likely to have decreased connections in their brain. So this is an important example. The early childhood environment can shape brain structure and function. In this case, it's shaping it for the worse, but we think prevention can shape it for the better, and I'll show you a couple of examples of that. Next slide. All right, so we talked about addiction is a brain disease, and we now have new technologies to help us understand that. We talked about development being important. While adolescence is the key period of exposure, the risk factors for drug use start much earlier. So we talked about the early childhood environment a little bit. Here's another example from an observational study. The Adverse Childhood Experiences Study surveyed youth about their experiences of childhood traumas, abuse, and neglect, and basically in this case looked at how many traumas did a youth experience, and then what were their chances of becoming drug users during their teen years. Compared to those that had no adverse childhood experiences, so none of these abuse or neglect symptoms, that's the 0, and you set that at 1, even having just one of these serious childhood experiences about doubles your chances of being a drug user later in life. Having 3 or 4 increases your chances about 4-fold, and having all 5 of them increases your chances by around 9 times compared to those that never had these experiences. So that tells us that there's something about early childhood environment, in this case the experience of early childhood neglect or trauma, that can predispose children to using drugs later in life. Next slide, please. Those are some of the principles that underlie the development of prevention interventions, and we'll go into this in some detail. But we've summarized some of these in a handbook that's available on the NIDA website called Preventing Drug Use Among Children and Adolescents. This is not a list of all effective prevention programs, but it will give you a sense of what it takes to be an effective or evidence-based prevention program, and it provides examples within all the major domains of drug abuse prevention that you might consider to select programs for your community. There are other lists as well, and if you're interested in resources, I encourage you to look at the SAMHSA website as well as the NIDA website for some of the best materials. And if that doesn't satisfy, write me an email, and I'll be happy to point you in some other directions. Next slide, please. As Mr. Botticelli pointed out, the key principle behind prevention interventions is to reduce risk factors and enhance protective factors. I was really pleased that he shows a keen understanding of the different domains and how these are nested within one another. So we can think about individual factors, whether that's the expression of aggressive behavior. So if that's a risk factor, then what can we do to help children not be so aggressive when they're little kids? How do we get them to learn how to restrain themselves and behave themselves better? Believe it or not, parents can be very effective in doing this. And so by helping parents be more effective, we can reduce things like early aggressive behavior or poor social skills. When it comes to adolescent period of life, the lack of parental supervision is a major risk factor. The lack of a parental loving environment is another risk factor. So you can actually provide coaching and teaching to parents about how to supervise more effectively and how to create a more positive environment for their children. We'll touch on a little bit of that as well. These are some of the examples of how prevention interventions are built on a platform of strong observational science. So all of these risk and protective factors were described in longitudinal studies of children as they developed. And then the interventions were designed to address some of these modifiable environmental factors. Next slide. I want to highlight for you one particular risk factor, which is self-control and self-regulation. All right, that's sort of a fancy psychological way of describing what it means to being able to restrain yourself or resist temptation. This is a fascinating study coming out of New Zealand that followed a little over 1,000 children from birth. They're no longer children. They now follow these individuals to their late 30s. But this study in Dunedin in New Zealand has produced a wealth of information. One of the measures they included when these children were 3, 4, and 5 years old was a measure of self-control or self-regulation. Now, what does that mean in a little kid? That means children who can sit still and follow directions a little better than average. Of course, no 3-year-old sits still very well. But we all know that children vary in terms of their ability to follow directions, to if you ask them to wait 5 minutes until dinner, until everyone's seated at the table before you start eating, that's an example of self-control and self-regulation. It turns out that the level of self-control and self-regulation, even when a child is that young, 3, 4, and 5 years old, is remarkably predictive of how they're going to do across a range of outcomes 10, 15, 20, even 30 years later. So let's look at all these graphs and charts here. Those who were low on self-control and self-regulation had more health problems. They were more likely to have addiction or substance dependence. They were more likely to have more physical health problems. When it comes to wealth or measures of being on welfare or financial support, those who were poor in self-control at 3, 4, and 5-year-olds were less likely to have an adequate income, were more likely to need financial support from their government. Even when it came to criminal behavior, those who exhibited poor self-control at such a young age were more likely to be convicted of a crime and serve time in jail or prison. I think it's remarkable, first off, that this study was conducted and was able to document that kind of behavior in 3, 4, and 5-year-olds. Took a great deal of foresight and effort on the researchers' part. But that it is so clearly linked to these major domains of social and physical health and outcomes is quite astounding to me. It also gives us the opportunity to think about prevention. Prevention interventions may be able to enhance self-control. It's certainly not going to completely change it. Some of these are innate abilities. Anybody who's observed children and had children themselves recognizes that all children come with their unique abilities, strengths, and weaknesses. And you have to work with those, but they certainly can be changed. And so that's the hallmark of prevention, is to address things like self-regulation and self-control and try to enhance it as a way of improving health, improving wealth, and reducing crime. Next slide, please. I think I've already kind of provided for you some of this background, but let's look in a little more detail about the modifiable risk and protective factors. These are the kind of things that we might consider for implementing as part of a prevention intervention. Early aggression. For example, there's a wonderful program called the Good Behavior Game that targets early aggression, and I'll show you an example of its effects in a little while. Social skills deficits. That's a program like Life Skills Training can work with adolescents and early adolescents to improve their refusal skills directly related to drugs, but also generally their social skills. Issues around neighborhood availability or even parental monitoring and support can be modified with interventions. These are all examples of how programs that I think of as prevention programs or prevention policies and interventions can make a major difference in the life outcomes when children are exposed to these effective and evidence-based prevention interventions. Of course, there are background factors that we have no influence over, and and need to take into account when designing the interventions. So making sure that that interventions are culturally sensitive and appropriate can be very helpful. There's some really wonderful new work looking at taking a family-based intervention and adopting it for American Indian tribes, and it's showing very important evidence of impact in those American Indian tribes when it's made culturally appropriate. Certainly thinking about whether children are at particular genetic or specific personal risk for drug use may be important. We haven't quite figured out how to do this yet, but understanding which youth are at risk and then designing interventions particularly for those higher risk individuals is a very promising approach that researchers are working on right now. Next slide, please. Now, I've highlighted for you that there are multiple interventions that have been proven to make a difference for reducing drug use. But there's a second theme that I want to highlight for you, which is that these very same interventions that might reduce drug use can be useful for other outcomes. We've been asked recently to work with the Department of Education in schools and highlight for them whether drug use interventions might make a difference for school outcomes. So I thought I'd highlight for you just a couple of examples of how drug interventions, prevention interventions, can have an impact on school outcomes. In a way, this is going back to that slide that related to self-regulation and all the different outcomes that it impacts. Not just drug use, but other important health outcomes can be influenced by these same risk factors. And that's one of the principles for why we might look at how drug prevention could impact academic performance. We all know that drugs themselves can make learning difficult. A teenager that is stoned and high in class is not going to learn as effectively as a child who's sober and paying attention. From the very practical way that they may be asleep in the back of the classroom to the more subtle way that their brain may not be able to remember or form the connections when they're trying to learn something that's complicated or difficult in a class. That's one part of the way that drugs can impact academic achievement. But the other way is building on this model I've been describing for you, which is how early childhood environments and development is important. Those very same targets that may be useful for drug abuse prevention are also related to academic outcomes. Next slide. I've got examples from all different age groups, and this is typical for drug abuse prevention. These are all proven drug abuse prevention interventions at the different ages. And I'll just show you one example from each of these about how they relate to academic outcomes. So they're all proven to be useful for reducing adolescent onset of drug use. What are the influence on academic outcomes? Let's look first at an infancy intervention. This might be surprising. Next slide. That an intervention when someone's 2 or 3 can improve their academic outcomes. The family checkup is a parenting intervention, so it's a fairly low level. It includes just a few sessions of support with at-risk parents. You provide behavioral support when a child is 3 years old, and it turns out when they're ages 5 and just entering school, or at age 7 or 8 when they're in about the 2nd grade, they do much better in school. So by helping parents supervise and provide a loving, nurturing environment when a child is 3 can make a much improved outcome for their school performance at age 5 or 7, let alone several years later when it may make a difference for drug use. Next slide. So that's just one example of how an infancy intervention can make a difference. Next slide. For early grade school intervention, I already mentioned to you that aggression is an important risk factor for the development of drug use. I don't think that surprises too many of us that have been clinicians or worked with kids. We know that the aggressive, difficult, obstinate, sometimes conduct disordered children are those who are most likely to be using drugs later in life. Some of the early evidence of this is children who exhibit aggressive behavior during kindergarten and 1st grade. Can we do something about this? The Good Behavior Game is a group intervention that helps teachers create an atmosphere that can create a pro-social, better learning environment. Now that's a fancy way of it teaches the kids to help one another pay attention, sit still, follow rules, not interrupt, and they get rewarded when they experience that good behavior. There's no punishment involved. It is all a reward-based intervention that shapes behavior of these little kids using positive reinforcement. Now, the good news is that, in particular, it has an impact on the aggressive and distractible little kids and helps them modify their own behavior in a major way so that they no longer end up being isolated and marginalized. They don't get labeled as being difficult children. They're able to stay in their regular classes. They're able to participate with the other children over the ensuing few years. It certainly improves their mental health and substance outcomes over time. But what's been intriguing to me and others is that it not only helps their drug use outcomes, but it helps their reading and math scores. So what you see on the left, the taller bars are either the boys or the overall groups that participated in the good behavior game, and the shorter bars are the control groups. So these are classes that either got the good behavior game or didn't. And those classes where the good behavior game was administered, the outcomes were better. And this is in grade 12. So what is that? That's about 11 or 12 years after the intervention was done. I pause now for a moment just to think about the implications of that. That tells us how important an early environment can be in that we can set children and set youth on a positive trajectory that might last a lifetime. Next slide, please. When we move to the middle school or elementary school, there are multiple interventions. And I'm just going to show you one example, the example being the Strengthening Families Program 10 to 12. This is a universal intervention that takes place in schools. It was originated in Iowa, so we used to call this the Iowa Strengthening Family Program. And Dick Spoth was one of the key developers of this. He's a wonderful researcher who's been teaching us about the importance of helping parents be better parents to teenagers as a tool for reducing the onset of drug use, and in this case, improving academic outcomes. So this is an after-class intervention, and so it's about 6 sessions after school. Parents and the children come to this. They work in separate groups and sometimes together, and that those who participated, who were assigned to the intervention and participate, end up with better parenting competency and less substance-related risk in the youth. So it's either the youth improvement for the children directly or improvements through the parent skills. Better able to provide supervision and creating a more loving, nurturing environment at home, which is often a challenge for parents of teenagers. So those that have teenagers at home, I think, will resonate to the idea of getting some help and advice about how to do a better job. What they found out is that school engagement improves. So instead of seeing those kids who are most at risk for dropping out or no longer being interested in school, they remain more interested in school, and then even by 12th grade, so that's about 6 years later, they are much more likely to be successful in graduating from school and having better reading and math outcomes. Next slide, please. This was a pretty broad and quick view of a tremendous amount of research into developing prevention interventions. So I hope it gave you a sense of the range, whether that's a range in terms of the age of the youth or the type of interventions that might be implemented. So what I'd like to do for the next few minutes is to move and switch gears and talk about first prescription drug abuse and the opioids in general as a major issue for all of us. And certainly you in the HIDTA program are well aware of our attention to the currently emerging heroin problem, but about a dozen years or longer of prescription opioid-related issues in this country. And I'll show you how both universal prevention, like I've been describing, may play a role in reducing this scourge, but I'll also talk about some of the other prevention and other types of interventions that we're using right now. So next slide. Let's talk about some of the background here. Underlying this opioid epidemic has been a push in the healthcare community and the healthcare system to improve the treatment of pain. Everybody recognizes that having serious pain can be disabling and totally miserable. When it's short-term, We are very effective using medications. So if you have surgery, you're extraordinarily grateful, and you're very lucky that we have opioids to treat that pain and to help control it for the short term. There was a move starting about 25 years ago to take that model and try to do a better job of treating long-term chronic pain by also using opioids. That seemed to make good sense. If you have pain, why not use a painkiller? The problem is that these painkillers, the opioids, those are narcotics like hydrocodone, oxycodone, Demerol, anyway, there are a couple dozen different trade names and chemical names for the different opioid derivatives, whether they are synthetic or semi-synthetic or natural compounds. They all act in very similar ways. But what happened was we ended up using more and more of these in an attempt to control long-term chronic pain. And at first, this looked reasonably useful. The problem is that we were setting ourselves up for some major public health issues. It turns out that the evidence for use of these agents long-term isn't very strong. When I look through the scientific literature, there are either no studies or the studies mostly show problems with the long-term use of these medications and show very little improvement when patients are followed long-term. So what you end up is somebody who's still not functioning very well, but now is dependent on opioids in addition to having their underlying health condition. That's a very typical outcome and is an unfortunate byproduct of the reliance on these in many cases when they were not warranted. This is a complicated issue, though, because the treatment of pain needs to be improved. And so what we're doing at the NIH is not only working to address the opioid prescription issue directly, but we're also trying to work on how to improve the treatment of pain. Because if we can't do that, I think we may never solve this opioid problem. So we need non-opioid approaches to treatment of pain. But I digress a little bit. This just shows you that the number of prescriptions has skyrocketed, about tripled over the last 20 years. Next slide, please. What we've learned, though, is that it's not just the increase in prescriptions, but paralleling this increase in prescriptions, and that's the blue line, while the sales of opioids have more than tripled in the last 20 years, we see that treatment admissions for being addicted to opioids has also increased markedly during this same time period. But of course, most disturbing, it's the number of deaths associated with these agents that has galvanized the public health and the law enforcement community to do something as quickly as we can to save lives and improve health. In 2013, there were almost 44,000 overdoses from one or more different drugs of abuse. The largest single category would be the prescription opioids. But I also point out to you that heroin, after staying at a fairly low level for a number of years, has increased markedly to over 8,000 deaths in the most recent data of 2013. Next slide, please. We've paid a lot of attention to the opioids, and the relationship of the prescribing to deaths related to opioids is well known to all of us, and I'm sure to all of you on the phone. What is less well recognized is that it's not just the opioids, it's also the sedatives. Now, as a physician, I was trained that benzodiazepines, that's medications like Xanax or Valium or Ativan, diazepam, chloride epoxide, etc., are relatively safe. They were introduced in the 1960s and came into widespread use for short-term sedation or for the treatment of anxiety disorders because of that safety profile. They are much safer than the barbiturates that they, for the most part, took the place of. So the very pills that killed people like Judy Garland and others, very famous overdoses at that time, are no longer widely used, and benzodiazepines are much safer when taken by themselves. What's less well understood by clinicians and by public health officials is that while benzodiazepines rarely produce a fatal overdose by themselves, when combined with other sedating agents like opioids, alcohol, and so forth, they can be fatal. So what you see here is that over the last, between 2004 and 2011, we saw that the number of opioid-related deaths, the number of those cases that included benzodiazepines increased markedly. It went from around 17% to almost 35%. So the rate of benzodiazepines, these other sedating agents, being part of the overdose doubled across that brief time period. Even when we look at emergency department admissions, that's emergency department visits involving opioids, those also involving benzodiazepines went up by about 50%, from 20 to about 30% of the cases. So this is an important lesson that what is a unfortunately all too common prescribing pattern of including both benzodiazepines and opioids for either pain patients or others is not a safe combination. And so that's a message I've been taking out to my clinician colleagues and trying to convince people to change their prescribing pattern. So that's some of the background in terms of the deaths and morbidity, that's harms like emergency department visits. Next slide, please. What can we do about it? I'm going to talk about some of our specific interventions, but one that we haven't really paid as much attention to in this field is how a universal prevention intervention can make a difference. I spent a lot of time earlier this afternoon talking to you about the importance of the early childhood environment, how these long-term developmental outcomes matter, how risk and protective factors can play a lifelong role in someone's growth and development. Well, here's an example of how that family intervention, the Strengthening Families Program 10 to 14, in this case, this is part of now 3 separate studies of this intervention. And when we look at the 3 studies together, we find that the children that were part of that 6th grade family intervention are much less likely to use all prescription drugs or opioids in particular. So at age 21, they are less those in the intervention, those are the blue bars, had less than 1% of them were abusing prescription opioids, while about 9% of those that didn't get the family intervention were using prescription opioids to get high or for their on their own. Even by age 25, we see it's about a 3-fold difference, where under 5% of the 25-year-olds had used had abused prescription opioids if they were in the family program, compared to around 13.5% in the comparison group. So this really reminds us that these trajectories, these early childhood environments, or in this case, a middle school environment, can make a major difference in the life course for individuals that are lucky enough to be exposed to these prevention interventions. Next slide, please. Of course, that's a long-term approach. We need to do something more rapidly. I would love to see all of our teenagers be able to partake in prevention interventions, but that's going to take many years for them to grow up and be less at risk and less abusing these drugs. What can we do more quickly? Well, one of the interventions we can do that can save lives today is to intervene directly for overdoses. So it's been well known in emergency departments and in healthcare settings that we can administer naloxone. The trade name is Narcan, so as a physician I thought about I used Narcan a number of times as a clinician to resuscitate people, or in my case I was also testing for their going into withdrawal to see if they might be able to use some of these agents long term for treatment. But we found out that that naloxone can revive people remarkably when they've overdosed on opioids. Now let me go back and help explain why that might be. Opioids produce their effect in the brains. They produce their effect on opioid receptors. So those are chemical receptors that are like a lock and key. And when an opioid gets in there, it's like you turn the lock, and that produces the effect, whether that's the euphoria and pleasure that drug addicts are looking for, or the pain relief that pain patients are looking for, or the sedation that no one's really looking for but is a side effect and is universal for opioid agents. Naloxone works like a key that goes in the lock, but it doesn't turn. So it blocks the lock. It fills it up and doesn't allow another opioid to get in there and produce the effect it was looking for. and it's very effective, and it's competitive, so it pushes other opioids out of the way. So that's why when somebody is not breathing, looks blue, and you administer naloxone within, if it's injected or in this case intranasally administered, within a few moments or a few minutes, they wake up and they're breathing on their own. So that's a remarkable life-saving intervention. Naloxone has been available by injection for a number of years. In about the last 15 years, some community organizations have been using the injection form among groups of heroin addicts, primarily in cities such as Chicago, San Francisco, and a few others, where they've been distributing the injectable form with instructions and education so that when somebody witnesses an overdose, they're able to revive the victim. More recently, people have been administering an intranasal or a spray version of this. They take the injection form, they load it into a syringe, but instead of having a needle, they put a sprayer on the end of the syringe, and they spray it in somebody's nose. This looks very effective. In fact, the state of Massachusetts has implemented this on a widespread basis and has shown strong evidence for its impact in saving lives and reducing overdose. Recognizing the value of an intranasal formulation, NIDA has been working with two different pharmaceutical companies, and both these companies have recently submitted their data to the FDA for what we hope will be approval, and certainly it's undergoing review right now. So I'm hopeful that we will have products on the market that will allow more widespread use of an intranasal formulation that will have been proven up to the FDA standards to be effective. Next slide, please. Now, I highlighted for you two particular interventions related to prescription drug abuse, but our range of approaches is quite broad. We thought about primary prevention, that's programs like the Strengthening Families program that I highlighted for you, the overdose intervention with naloxone, whether that's administered by an injection or intranasally that we're hoping to have available very shortly. But we can also think about developing less abusable analgesics. This will not reduce the abuse when it's taken by mouth, but it may reduce the ability, if you have pills that can't be crushed or don't dissolve very readily, then people are much less likely to take them by nose or to inject them. But more fundamental, we think that educating clinicians about their prescribing practices, we'd like to reduce the number of leftover prescriptions in people's medicine cabinets. So perhaps when patients are discharged from the hospital, instead of getting a 30-day prescription for opioids, they might get a 2- or 3-day prescription. That could go a long way in reducing the number of leftover medications. That's just one fairly simple approach. We certainly know that programs like the prescription drug monitoring systems can help identify the highest risk patients, those who are doctor shopping and are truly addicted and are using the medical system to obtain their drugs of abuse, that might help identify those individuals. And we expect to engage them into addiction treatment. In particular, I'm very grateful that we have medications that can be used to treat heroin and other opioid addictions. So we have substitution treatments like methadone and buprenorphine. We have a long-acting blocking agent called naltrexone that can be injected once a month that can block the effects of opioids, and that looks like a very promising approach. There are also non-medication approaches that can be combined with medications to enhance their effectiveness. So treating the addiction, educating clinicians, educating the public can be some of the other approaches in addition to the direct overdose intervention that I highlighted for you and the primary prevention that we talked about as well. Are we making a difference? Next slide. Well, so far it's much too early to conclude that we have succeeded, but we are seeing some early indications that we might be moving in the right direction. We are seeing that among the teenagers, we see less misuse of opioids. So this is over the last 4 years. We've seen a reduction in the number of high school seniors reporting use of narcotics other than heroin. That means pills like Vicodin or oxycodone and so forth. It's down by about 50% from a peak of just under 10% to around 6% now in the 12th graders. That's very good news. Next slide, please. We have also seen a leveling off. I won't say much of an improvement, but at least a flattening of the increases for prescription opioid deaths. That's mixed news, because at the same time as we've had an improvement for opioid prescription-related deaths, we've had a skyrocket in the number of heroin deaths. So that's when I say there's some evidence that we're beginning to make a difference, but we have an awful lot more work to do. Next slide, please. Okay. I have highlighted for you the developmental origins of drug abuse, the importance of risk and protective factors, the developmental trajectories and how the early childhood environment is important. We've talked about prescription drug abuse as one of the major current epidemics that all of us are working on. The last set of issues I want to highlight for you is relates to the shifting marijuana legal environment. Certainly this is another major drug use issue that all of us are dealing with. Next slide, please. What is surprising to many individuals is how many people use marijuana on a regular basis. It's about 8 million individuals use marijuana on an almost daily basis. So there are in total about 20 million persons who use marijuana in any given month, but around 40% of those, or 8 million total in the United States, use marijuana 20 days or more out of a given month. So by my arithmetic, that's more or less every day. That's a lot of people using marijuana on a nearly daily basis. Next slide, please. In addition to thinking about the number of marijuana users, an important issue has been that the potency of marijuana has been increasing. This is data that comes from a project out of the University of Mississippi that looks at marijuana seized in police actions all across the country, and they've noticed that over the last 20 years, the potency of the marijuana in this police-seized marijuana has about tripled, has more than tripled over the last 20 years. So the marijuana used today is not the same as what was used 20 years ago, and that may make a difference in terms of the health outcomes. Next slide. In addition to the sort of the shifting legal and social environment that we're all well aware of, this is having an impact on youth attitudes. So what we've seen in the annual surveys of adolescent youth use of marijuana, there are annual surveys done in schools all across the country, and this study, called the Monitoring the Future study, has been documenting for many years the amount of drug use in this country. In addition to documenting how much drugs are used, they ask about attitudes towards drugs, and they've identified that the perceived dangers, so whether kids report that marijuana looks risky to them, has been declining. In green, you see the 12th graders. Under 20% of 12th graders think it's risky to smoke marijuana occasionally. Even among the 8th graders, it's under 40% think it's risky to smoke marijuana occasionally. And that's a marked decline from just 10 years ago. Now, if it were just an attitude, I'm not sure that we would be so worried about this. But attitudes are linked to behavior. Next slide, please. What we see is that when you look over the long term of the Monitoring the Future study, in green, you see the use of marijuana every year since this study started in 75. So it was around 40% in 75. It increased to around 52, 53% in the late 70s. It declined across the 80s. It went up again in the 90s. And then it's been waxing and waning since about 1996. Look in red. This is perceived risk of marijuana use. It looks like a mirror image. So when I say that the perceived riskiness among the teenagers has been dropping, this matters because it's so strongly correlated to how much they use. So attitudes towards drugs are a predictor of use of drugs later on. Next slide, please. In fact, what we've seen is a disconnect where marijuana used to be less common than either cigarettes and particularly much less common than alcohol. We now see that marijuana use is more commonly reported by youth in the United States than cigarettes and nearly as commonly reported as alcohol use. This is a remarkable shift in the behavior of teenagers in our country. It speaks to the improvements for alcohol and tobacco and the lack of improvement in terms of marijuana trends. Next slide, please. Now, given the shift in attitudes, we know that this is part of a broader social change. And what you see in this one slide is just a snapshot of the states that have either decriminalized, provided medical approval for marijuana as a so-called medical product, or fully legalized it, which we've most recently seen in Oregon, Alaska, and the District of Columbia, and then a couple years earlier in Washington and Colorado. So this is a major shift in terms of the policies. And our question is, from a research perspective, is, okay, does this matter? Does this make a difference in terms of youth use of these drugs or young adult use of these drugs, and what about the health outcomes? Are they worse when you make a drug legal? We are engaging in a number of studies in these states that have a shifting legal and social landscape, and we hope to bring answers to those questions both now and in the future. Next slide, please. For example, researchers at Columbia University have been looking at the states that legalize marijuana, and they find that those states are more likely to have high rates of marijuana use. And because of that higher rates of marijuana use, they have higher rates of addiction or marijuana abuse or dependence. Now, this doesn't tell us that there's a causal link, because this isn't tested over time. What this shows is that cross-sectionally. And you could certainly have the idea that the very same states that might pass laws to legalize marijuana are also those where it's more commonly used. So this is not an easy issue to study from a research perspective, but it's certainly one that we continue to track and monitor. Next slide, please. What the high school study has been showing us, though, is that even though marijuana is not, medical marijuana, for example, is not legal for persons under the age of 18, that for those kids that live in a medical marijuana states, they are much more likely to obtain marijuana from someone else's medical marijuana prescription than when they don't live in those states. So that's pretty typical, that when you make a drug available one way or another, it will find its way into the hands of youth. Next slide, please. It's not just availability in the medical marijuana states, but we also found that use of edibles is higher in those states. And I think this is an understudied phenomenon that you all may have some insights into in terms of the edibles that are available in some of the states where you work or in some of your regions. And this represents a much less well understood issue in terms of the effects of cannabinoids and marijuana when taken by mouth. We're pretty familiar with what happens when it's taken by lung, by smoke, but the ingestion by mouth is much less well researched. Next slide. I also want to highlight for you that the behavior associated with marijuana may be changing. Again, from the Monitoring the Future study, we see that driving a car, truck, or motorcycle, so operating a moving vehicle, is more common after smoking marijuana than after drinking now, and that's been true for the last 5 years. So there are a number of ways that we need to work together to understand the impact of the shifting marijuana environment. I particularly want to highlight for you, next slide, some of the health outcomes. One key issue has been that marijuana users show, those who use marijuana heavily during their teen years and continue to use it for a number of years, that they show a decline in their IQ. That means they lose intelligence over about a 20-year time period when they use marijuana both as teens and continue to use it. Now, that's not the most typical course. Most individuals don't follow that chronic long-term course, but it begins to speak to the riskiness, particularly with heavy, consistent use of these substances. Next slide. Another way of looking at this has been looking at other outcomes. So this is, again, a series of studies that come from Australia and New Zealand, 3 large population studies that followed youth from their teens into their 20s and compared those who never used marijuana, those are the light-colored bars, to those that used either rarely or weekly or daily. And what you see is that the frequency of marijuana use during the teen years is associated with less educational attainment, so lower likelihood of completing high school, much more likely to be dependent on marijuana or cannabis, much more likely to use other drugs, and even more likely to attempt suicide. So there may be links between marijuana use during teen years and a variety of outcomes when these individuals hit their 20s. Next slide. Despite this important data that I'm able to share with you today, there's a lack of full information about the impact of drugs on the developing brain. Because of evolving technology, we are able now to launch a large-scale study, and we're in the process right now of funding a series of sites to help us with a longitudinal study of some 10,000 children. We will start investigating and learning about how they're doing when they're 9 and 10 years old, before they've started using drugs, and that's key. We want to take a picture of their brains using MRI scanning and learn about their family functioning, their school functioning, and their current status before they start using drugs. And then we will talk to them every year or 2 years over the next 10 years or so in order to determine what happens to them. And unfortunately, some of those kids will start using drugs. And so we will learn from those individuals what happens inside their brains and what happens to their academic, social, and emotional development over time. This is some of the exciting science that we hope to be able to present to you in the future, but I don't think you need to wait for this study to take action. I hope you've gotten from my description of all of the prevention interventions and some of the developmental and neuroscience that stands behind them that there's a lot you can do today. Next slide, please. In particular, I highlight for you how healthcare reforms and the emphasis on prevention and the ability to fund prevention services may provide some new opportunities to support prevention in the very communities we all care about. This is really a remarkably exciting new opportunity for improving the health of the community, both by providing insurance to those who didn't have health insurance, as well as improving the essential benefits package to those who do have health insurance, and need to make sure it includes the key components that will keep families and youth healthy for the long term. Next slide, please. I'm wrapping up now, and then we'll open it up for questions. I hope what you've gotten from my lecture is that neuroscience and developmental science can teach us about the background for prevention intervention development. Reminds us that drug use starts during the teens, but the roots of drug use in terms of the risk factors and the protective factors start at birth or even before birth. And prevention interventions can be implemented either with newborns, with early childhood interventions, with middle school kids, with high school kids, with college students. These are all places where prevention can make a difference in the life course of the individuals and the communities that we serve. Thank you very much for your attention. Last slide, please. Now, I think I'm supposed to help field a question and answer session, but I'm going to get some help here from my colleagues here in the room. And we'll start out with some of the questions that were sent in ahead of time. But those who are listening in, please help me and ask some questions yourself. I really like to hear and make sure I've had an impact and am able to address the concerns and issues you may have. I will say that a webinar format doesn't always work to answer questions, so that if something comes to your mind afterwards, feel free to send your colleagues at ONDCP the questions or send them directly to me at the National Institute on Drug Abuse. So I'm happy to take any questions now.
Okay, while we are waiting for questions to queue up, we'll ask some of the questions that were submitted during the registration. So the first question is from Mr. Daly, Director of Philadelphia Camden HIDTA. Dr. Compton, is there any evidence that coercive or mandatory attendance in substance abuse prevention programs are any more or less effective than self-initiated, voluntary attended ones?
Well, I know you're familiar with that concept coming out of the treatment paradigm, where we've known for a number of years that requiring treatment, whether that's through such programs as drug courts or through even family encouraged or not quite coerced or required, but pretty close to it, interventions can be just as effective as when they are completely voluntary. So that's true for treatment. It's a wonderful question when we try to apply that to prevention. It's a little bit tricky because we really don't have coerced or required prevention. I find that concept sort of is a little misleading because prevention is implemented before there's any use of drugs. So there's nothing to coerce people to be part of. On the other hand, some prevention interventions are administered in schools And so they take advantage of the fact that kids are in the classroom, are really not going anywhere, and are available on a universal basis. So irrespective of whether they're interested or not, they'll be in the class. And so in a way, we can think of some of the classroom-centered interventions as being the equivalent of sort of not as voluntary or not as optional for the interventions. And they do show a good impact. One of the things that's interesting to me is that family intervention I described for you, Strengthening Families program, only seemed to reach about a quarter of, in the best cases, about a quarter to maybe a third of the families that could participate in those programs, and yet it still shows an impact on the overall population when it's used. So it may be that even if not everyone goes, that they share the information with other parents or with other kids, and it may turn out that those who are most at risk show up for some of these interventions. But it's certainly true that if you don't participate, you won't benefit ultimately. So finding ways to encourage participation is an important aspect of implementing prevention.
The next question comes from Mr. Shergood, Deputy Director of Puerto Rico, United States, Virgin Islands, HIDTA. Dr. Compton, as a program starting up, what lessons learned would you want to pass to us to ensure we are more on target with the student audience?
Well, I think most important is taking a five-step approach to implementing prevention. There's the programs like the Community That Care program, which is available on the SAMHSA website. There's the Strategic Prevention Framework that's a multi-step process that SAMHSA has also promulgated for how states and territories implement their prevention approaches at a state level. And what I mean by that is the first step is to organize and do a survey and find out what the needs in your community or in your school are. So it's all well and good to think about what you might like to do for a prevention intervention, but if it's not targeting the risk factors and the problems that are identified in your school, you may not be as efficient or as effective as you'd like to be. So starting out by learning about what are the risk and protective factors in your school and in your community is step one. And then selecting evidence-based approaches that address the identified risk and protective factors is step two. Step three is implementing the evidence-based approaches in a meaningful and correct way. And that's not as easy as it sounds. Some of the prevention interventions take training, require careful thought to be able to implement them correctly. And then, of course, at the end of the day, you've got to track and see how you're doing and see if you're having the impact you thought you were. There are many times when we hope to make a difference and we don't have the impact, and so you have to regroup and try something different. It's a long haul, this community development and prevention approach. What I bring to you is evidence that when you keep your mind to it and keep yourself focused, you can make a difference in the long run.
Next question comes from Ms. Simmons Isanasan, Executive Director of the Virgin Islands Domestic Violence and Sexual Assault Council. Dr. Compton, what information can you provide on the intersection of substance abuse and family violence, and how can prevention programs address this?
That's a terrific question. How do substances relate to violence, family violence, and other forms of violence? Well, there's sort of two ways. One would be the direct way, in that people who are intoxicated, particularly on certain substances, are much more likely to be perpetrators of violence. So the most obvious example and the best known one would be alcohol and its disinhibiting effects. Alcohol is well known for being associated with violent behavior, and every police department in the country is familiar with that in terms of domestic violence issues. It's not as clear the other substances, how specific they are associated directly with violence. Some of them not so much. Opioids and heroin are not associated with violence, for example. It makes people sleepy and sedate, which is sort of the opposite of what you might expect to be becoming violent. On the other hand, when people are going through withdrawal or as part of trying to obtain drugs, they may engage in extremely violent behavior in terms of robberies, assaults, and others to feed their habits. So they're a complicated way that these are related. Now, you asked about prevention interventions. Can they make a difference? There are crossover effects. So just like we pointed out that if you can address early childhood risk factors and reduce the onset of drug use, you can also reduce the onset of aggressive behavior and violent behavior. And so if you're interested in more specific links, send me an email and I'll help you find some of the literature on that link. But programs like life skills training have been proven to have crossover effects, and some of the others have as well. Now, Marilyn, I think we're open for questions online if there are any.
Great. So let's go to the line of Jeremiah Daly. Your line is open. Please state your name, organization, and question.
Hi, it's Jerry Daly, Philadelphia, Camden, HIDTA. And I'm just kind of curious why you chose to present naloxone as a prevention tool. I've always viewed it as a harm reduction tool, maybe a pathway toward treatment, but it seemed an odd place to put it in prevention.
I agree with you that naloxone is a very different type of prevention. Prevention can have a variety of meanings. Most of the talk today has been focused on primary prevention, on the ways to reduce the initial onset of drugs, and you're absolutely right. Of course, naloxone is the most distal end of an intervention. It's when somebody has already engaged in the most extreme form of behavior, and we're trying to save their life. But it is prevention when it's thought of in terms of preventing mortality. But you're absolutely correct that it fits more in with a harm reduction and life-saving approach, and in some ways a little bit of a Band-Aid approach. What you pointed out, I think that makes a little too light of it, but it is a short-term intervention, and so it of course is life-saving in the immediate consequences. But we hope to see it being linked to more fundamental interventions like addiction treatment.
Thank you.
You're welcome.
All right, now let's go to the line of Steve Shagrud.
Yes, Dr. Compton and Jamie, can we get a copy of these slides? Or
yes,
some of them
be
just
sending we have an email all prepared to send to you right after the webinar.
Great. Really enjoy Dr. Compton. Good.
You're welcome. And you're welcome to reuse these slides. The taxpayer helped develop them, and they belong to every one of you. If you have any questions about how to interpret them, feel free to shoot me an email.
All right, let's go on to our next caller, Anthony Soto. Your line is unmuted.
Thank you. My name's Tony Soto. I'm director of the Gulf Coast HIDTA, and we have a concern here in our HIDTA. There's several states that are considering marijuana legalization, and it would be a great help to us if we had a list of professionals that would be willing to testify at our expense before some of these committees to try and educate the state legislators in those respective states on some of these dangers, and it sure is more effective coming from a professional like you, doctor, or other people that are willing to perform that service on our behalf.
Sure, I'd be delighted to make some suggestions. I'll send those to ONDCP. One key person that you all may be familiar with, if you've been in the field for a while, is Bertha Madras, who used to be the Deputy Director for Demand Reduction here at ONDCP. And she's been very important in a federal case in California related to a potential change in the scheduling of marijuana, and has a great deal of experience in testimony and testifying. But there are a number of others who might be very helpful and useful. We tend not to volunteer for those as federal officials from the National Institutes of Health because of the restrictions on our ability to influence pending legislation. It's often better if it's an outside person. But there are times when we can help as well with the educational material that we're always willing to share and look forward to distributing to everybody who needs to learn more about these issues.
Thank you.
All right, and we have no further questions on the queue.
Well, I want to thank those of you who did pose your questions. It's very gratifying as a speaker to at least know that at least 3 people were listening. And with that, I thank you very much for your attention, and I think we'll turn it over now to Michael Gottlieb.
Great. Thanks, Dr. Compton. Really appreciate it. interestingly, I had to step out. Folks on the webinar are not going to know this, to take another phone call, and not only were the participants in the HIDTA community learning and listening, just walking through the halls here at ONDCP, saw a whole number of folks in their offices listening to the webinar as well. So your expertise is not just being imparted to the HIDTA stakeholders, also to staff here at ONDCP. So we appreciate you taking the time and sharing your expertise. It is no secret to anybody on this call, anybody in the HIDTA community, that we have sought for the past couple of years and really made a concerted effort to get the HIDTA program a bit more in line with the prevention community. And to make this program not just about law enforcement, but have law enforcement partner with our public health stakeholders and vice versa, working with our DFCs, for example, to have them work more closely with our law enforcement community. And we have been very pleased and very heartened by the participation in this webinar and the participation of HIDTAs in our prevention initiatives generally. I think we're up now over 22, probably even higher than that in terms of the number of HIDTAs of the 28 that are actually involved in prevention activities at this particular moment. And that's a significant increase from a couple years ago. So thank you all for your efforts in that regard. I could go through each of those 22 or 23 initiatives, and they would look different, and they would feel different, and consistent with the HIDTA mantra of no HIDTA being alike. We have prevention initiatives in New England that deal with physicians. We have prevention initiatives in the Northwest that work with specific segments of school populations, and across the country we go, and that's really the beauty of the program, taking sort of the science basis, the evidence basis that Dr. Compton talks about, and making that your own in your community, in your HIDTA. Next slide, please. One of the things we wanted to do here, obviously, is to provide sort of a foundation on good practices and the good science in prevention. And this webinar is a start. But there are a number of other agencies and a number of other publications that we wanted to make you all aware of and provide as resources. So you'll have the link on these slides once we send them out and send this email out after the conclusion. We're also going to post this up on the NHAC's website, so folks can access this, and their stakeholders and folks within their HIDTAs can access this 24/7. The first slide, and I'm going to go through these quick. You all can see these, and you can see the titles and see the sponsoring agencies, but they vary from NIDA to DEA. Next slide, please. To a whole host of others, both involving ONDCP and our programs. The director mentioned the Drug-Free Communities program. I know everybody on this call is intimately familiar with that. Again, NIDA, DEA, SAMHSA, as well as some infographics to provide some additional depth. Next slide, please. And again, these resources we think will be useful to you all going forward. So our goal today was to improve your awareness of substance use prevention strategies, and again, thank you to Dr. Compton. I think we made great headway. I would be remiss in concluding our webinar today if I didn't just thank Dr. Compton and Director Botticelli, but also a number of folks in this room who really worked very hard to put this together. These webinars don't happen by magic, so staff in the Demand Reduction Office, folks in the Office of State, Local, and Tribal Affairs, a whole host of our summer interns that helped put this together as well. We couldn't be more proud of how this came out. Hope you all agree. Look forward to engaging with you on this topic more in the future. To the directors on the call, we'll be back in touch with you all probably within a half hour with Director Botticelli on some other HIDTA issues as well. So thank you for making this sort of ONDCP afternoon. With that, thank you again and goodbye.